I love the question, actually, because one of the most difficult things is when you start bringing up a taper, especially if you don't have the patient's buy-in. Ultimately, and what we covet, is to have the patient's buy-in to a taper. You explain the clinical reasoning process. Perhaps a patient has an exacerbation of COPD and compromised renal function, and that just the general physical health requires a lowering of the opioids because it's just an unsafe dose and they're accumulating. So you go to the patient and you say, I really have to bring the opioids down, or I have to extend the intervals in between. And so I need you to understand that. And so, of course, there's the anxiety part of it. And we're not even talking about drug seeking. Certainly, there are patients with OUD, with addictions, that is true, and that is a pertinent point. But let's say this patient is strictly been adherent, it does not have OUD, but he's anxious, he or she is anxious, because we're all going to taper the opioids to a certain degree. Maybe not all, but to a lower, safer dose as a compensatory dose reduction for general health reasons. So we look at that and we talk to the patient about it. So we have one patient that says, no, I'm all for it, will you go slow? Absolutely, that becomes the olive branch, because we can always fall back and go, we used to do it this way. However, for you and the way we do things now, we're going to take it very slow. And as long as your general health allows, we're going to continue. If we need to hold for an extra month, we will. It's not about how fast we get you down. In fact, it's based on your general health. We're going to work with you. Also, to make sure your pain doesn't escalate, and data shows that pretty much if you take a slow opioid taper, the pain does not increase. That's a big fear. So you have to have that conversation. And you can actually share, I don't mean the details of the data, but the summary reports with the patient. I would, and I have. I said, here's the basic take-home, and I outline, just highlight. And that shows them it's not just Robert saying, oh, no, this is true. Here's the studies that show it. Plus, we're going to offer some alternatives that actually we should have already offered, but since we have it, let's go down this road. Whether it's acupuncture, chiropractic care, massage, whatever the case may be, cognitive behavioral therapy, skills relaxation, and those types of things. But we will get the patient to go who's terribly resistant. And then you have to say, we are going to do it because your general health mandates that we do. I'm going to lose you, and I'm not going to lose you. I'm going to make that medical decision. And I have had this patient, sit with patients, and many, many times over my 13 years in the VA. I sit with them down personally, I take the time, and I say, look, I know you don't agree with me. I know you're afraid, but we're going to be with you step by step. I tell them I'm an old country boy, I'm a straight shooter, I'm not leading you down a bad road. And I said, you're going to be okay. We're going to do this slow, and we're going to take good care of you. And it works famously. Yes, there are patients that are resistant, but sometimes you have to get them down. And honestly, when opioid use disorder or addiction has not been involved, we've done extremely well with it.
Yeah, that's, I mean, to your point, I think talking to patients, the idea of patient satisfaction is no different than client satisfaction or any type of satisfaction survey. People become satisfied or are satisfied when they feel they are heard, when they feel they're getting the best care or the best treatment. And I don't think that necessarily is anything other than somebody speaking to a patient as a human being, not as a parent, not in a pejorative way, just to make sure that they understand that the goal of making them healthy is ultimately going to be satisfying for them. Because really what we're trying to do is get people as healthy as possible. Whether it's taking a diabetes medication or a heart or blood pressure medication which has side effects, patients aren't necessarily satisfied. They understand the reason for it. And I think one of the things we've done a poor job of is explaining the reasons for these tapers and the reasons for reducing medications. It comes off a lot of times as fear-mongering to patients. And I think if they understand, as Robert was saying, the data points, why are we so concerned? In a way that they can understand, then I think most people are on board. They just need the time to understand, and the provider needs to spend that time, because this is it's a fragile moment for that patient, because they feel like they're about to be left in pain. And I think that's a really tough place to be for anybody.